Yes. Okay. So you can give the talk. So it is my pleasure to announce our next speaker, Professor Mathias, and I think you're going to talk about tips and tricks for the service. Is that correct? What can go wrong in thrombectomy? What you need to know in 2026. Thank you, Klaus.
Yes, when you talk about complications, naturally nobody wants to have a complication, but the reality is we have them. And so there might happen something during the intervention. Access site, vessel injury, dissection, perforation, and so on. But also after the procedure, you have to be careful because there are reperfusion injuries, yes, brain edema, even cerebral hemorrhage might occur. It starts with the indication. The indication is wrong when the brain tissue is already severely damaged. The first step is naturally when you have a CT that it's not a hemorrhagic stroke, but an ischemic. And as you know, yes, the brain tissue dies step by step. First, when the patient develops symptoms, only the brain cells do not work anymore, but they are still alive. And when that goes on, then they will die. Therefore, time is brain. You have heard that now several times, so I can go on. And CT must tell us, yes, is it an ischemic or hemorrhagic stroke, already stroke signs, size of perfusion deficit, do we still have a good blood volume, and where is the occlusion located. So some signs, you're familiar with that, is CT, the dense media sign. And you see perfusion, yes, it's under-perfused MCA territory. What is very important, and I address that to all the colleagues who are doing with that, when you have ruled out an hemorrhagic stroke and it's an ischemic, and he's a candidate for thrombectomy, look at the blood pressure, it's very important, and have it high enough because there is still some circulation there by collaterals. So don't let the blood pressure go down when you start anesthesia. Yes, optimal pressure is even a little bit above normal. So you can go up to 160 systolic pressure, then you have a better collateral flow. After thrombectomy, vice versa, you have to get it down because you don't want to have some bleeding or edema. So blood pressure control and regulation before and during the intervention is very important. Yes, treatment options. We have already covered that theme of thrombolysis that can be performed intravenously and intra-arterially, but we do normally now extraction and aspiration of the thrombus. But you might have different complications with all these techniques. During the intervention, yes, you can have peripheral embolization, artery dissection, and also perforation of arteries. IV thrombolysis, yes, that is a little bit questionable, but still it is widely spread and used because when you have ruled out bleeding, then you can start it that immediately in the T room. Yes. With larger thrombus, it's always ineffective, and it has to be a fresh clot. When the clot is older, then it's also not working. Thrombolysis naturally is contraindicated, as I already mentioned, when you have an infarction with bleeding. Yes, thrombectomy, we have the different techniques, as you know, yes. And that works fairly well. In my experience, you see here an example, MCA occlusion, yes, before and afterwards, works very well. the clot. Yes, thrombectomy. Naturally, disrupts the blood-brain barrier sometimes. Yes, you can cause mechanical injury. Despite successful recanalization, reocclusion can occur. Yes, it can occur on the table with the patient in the angio suite, but it also can occur during the next 2 days. Reocclusion include, yes, elevated platelet counts and residual thrombocytopenia. Then, yes, when you have the higher concentration of circulating platelets, also can adhere at the lesion, and therefore we can give some medication to get the risk reduced. That was a very short contribution to that. And as you see, yes, when you have any questions, please ask, because I have to give a talk in the other room at the same time. We are a little bit above our time schedule.
Thank you so much. Thank you. Maria, would you?
As we understand, this is the brain worth saving, yes?
Yes.
Maria, would you connect it? Yes.
Yes, you have seen it was successful. There was no stroke and no bleeding.
Then yes, go to your next lecture, and it is my pleasure to introduce Dr. Maria Politi, who is an interventional radiologist and neuroradiologist, and you are going to talk about the changes within the devices, distal axis and aspiration evolution from the first aspiration case to where we are today. Quick question to the panel: do you also use so you use aspiration as a first approach always? Mm-hmm. So I do the same.
It is my first line policy.
Yes. It is also our first line policy, and then we can still combine it very easily with a Salumbra technique, combining both.
Faster? Yes. It's faster, yes.
Perfect, thank you.
Especially at 3 o'clock in the midnight.
In the night, yes. Good, and we are going to have a short change in the program, and it is my absolute honor.
First of all, thank you for allowing simple cardiologists to be included in your session. Момчета, тук няма дистанционното засмяне на слайдове, може би вие ще трябва да ми помогнете. Давай следващия. Next. So I will speak about basilar artery thrombosis and thromboaspiration. That is a little aside of the mainstream of the guidelines and also the trials, but it's an important vascular territory. In fact, the rapid onset of advanced motor and bulbar symptoms with a decreased level of consciousness, this is one of the possible presentations. Insidious or stuttering symptoms over a few days as a combination of the above, and the end with disabling motor and bulbar symptoms up to coma, and all prodromal symptoms that may include headache, neck pain, loss of vision, binocular diplopia, dysarthria, dizziness, hemiparesis, paresthesia, ataxia. So very versatile symptomatology, but with a very bad prognosis. In fact, the acute stroke caused by basilar artery occlusion accounts for 27% of the strokes in the posterior fossa. Unfortunately, the natural evolution is devastating, with mortality reaching 80%. Unfortunately, the 7 big positive trials for endovascular intervention didn't enroll patients with basilar artery occlusion, and there are only small series for thrombextraction in basilar artery territory published to date. Early basic prospective observational trial showed similar results between best medical treatment and catheter-based treatment, but there are some recent data showing very. Между другото, това не е презентацията, която съм аплоднал. Бях ви помолил да я сменим. Да, за съжаление. Okay, this is an old version of the presentation, but I will tell you what is the new positions. Thrombectomy and thromboaspiration were safe for treating acute basilar artery occlusion with low rates of mortality. This is good. And a very low rate of symptomatic hemorrhage and procedure-related complications. There are several very promising trials during the years, including during the last 2 years, fortunately showing very good results with successful reperfusion of 91.5%, definitely translating in a very good also clinical scenario. So this is the most important. This is in fact in our series of patients with basilar and middle cerebral artery, with 72% of achieving TC2 and 3 flow in this situation. The new evidence and trial data, there are some new evidence and trial data, despite based on relatively small series. Nevertheless, these major meta-analysis from the late 2024, including 4 trials, provided the strongest evidence to date. It showed that patients receiving endovascular treatment were 2.5 times more likely to regain independent walking compared to those on medical management in the basilar field. What about the durability and of the benefit? In fact, the long-term follow-up was very important. And this year in JAMA Neurology, attention trial was published with excellent 3 years durability of the treatment with a significantly lower mortality compared to the control group. What about the so-called extreme severity? Let's say desperate patients, including extreme severity with NIH-SS more than 25%, there's still chance. In fact, in these patients, the only chance is to make something, to make a recanalization, because otherwise, for sure, they will die. So the so-called coma state can continue even years, but finally they are dying. So we don't have any other, this is our responsibility to do something. And what we can do, we can recanalize the artery. As you see that the new recommendation based on this data that I have shown, the primary indication even NIHS score more than 10 and aspect more than 6 and with a very large window, treatment window 0 to 24 hours, even beyond 24 hours. And this is also very important to mention that in the trials, the preliminary previous intravenous treatment, thrombolysis, didn't change the results, so didn't increase the hemorrhagic conversion rate and so on. And even the best medical management and the thrombolysis doesn't preclude the excellent result of a small series of thromboaspiration. I'm presenting here a very interesting patient. In fact, he came in coma. He came in coma that lasted approximately one hour before coming to the hospital. We had the history 3 days before for a mild ischemic stroke with several comorbidities. The most important in this scenario is the paroxysmal atrial fibrillation with total canceling the anticoagulation that was prescribed. So naughty patient with this result. The result was very bad coma scale with very high NIHSS stroke score. On the imaging, you can observe this hyperdense sign for basilar artery occlusion, telling us about occlusion, and the strategy in the multidisciplinary team, definitely with the proposition that the basilar artery occlusion is the guilty vessel, and we decided to do something, as I mentioned, and based on also on the trials, and we have found this situation. The tip of the basilar artery totally occluded without any vessel after the basilar tip. And we decided immediate intervention. We succeeded, similar to our recanalization practice in the coronary field. We succeeded very easily to cross, obviously, a relatively fresh thrombus, probably thromboembolism in the context of his history of paroxysmal atrial fibrillation. And after making a thrombospiration, we had this residual stenosis. Just a remark, in the vertebrobasilar field, the atherosclerotic lesions are much more often frequent compared to the middle cerebral artery and the other fields. And because of that, because of the insufficient result of the thrombospiration that we extracted this thrombi, we did post-dilation with a non-compliant balloon, even a slightly undersized non-compliant balloon, in order to avoid dissection, of course, and this excellent restoration of the flow and acceptable residual stenosis of not more than 20%. For the surprise of the team, anesthesiology team, because the anesthesiologists, they all they know that there is no scenario of waking up from coma caused by basilar occlusion, and for their surprise, the patient on the next day woke up and started speaking. And yes, the evolution, the clinical evolution was really excellent, and he was discharged approximately one week after from the hospital. And this is the imaging control showing very good patency. We published this case. Second case related to stenting, possible stenting in this zone. There is a publication telling us that the results with balloon expandable stents are better compared to the self-expandable. And in this situation with a critical stenosis of hyperdominant left vertebral artery, and also practically thrombosis of the, mimicry of thrombosis of the tip of the basilar artery after ballooning and stenting with coronary, in brackets resolute tonics, following the size of the vessel. We succeeded to have excellent TC3 result with very good imaging and clinical outcome. Some tips and tricks: baseline angio, MRA or computer tomography is crucial. Use soft tip guiding sheets and guiding cutters in order to avoid spasm of the underlying vessels. For access to the basilar artery, go through the dominant vertebral artery in order to have a better flow. In type 3 aortic arch and bovine arch, radial approach is the access of choice in order to avoid too much manipulations in the arch and avoid the risk of embolization. And I mentioned already the guidelines. They are, let's say, raising the indication for basilar artery intervention as well, compared to LVO, very similar to the LVO. As a conclusion, the basilar artery occlusion is a devastating condition related to high mortality rate. Immediate recanalization strategy has to be undertaken regardless the time window and the severity of the symptoms. Both thrombospiration and thromb extraction are feasible and safe, and despite lack of large randomized trials evidence, the clinical guidelines encourage the endovascular treatment as well. Thank you very much for your attention.
Ivo, thank you for sharing these challenging cases, but we all know that posterior fossa is a different space.
Absolutely.
For sure, we have one clear message that for this particular patient, we should do something, otherwise we will use it.
Yeah.
So for me, in my mind, it was a very, very challenging case.
Thank you.
Really, thank you so much for showing that. And it also shows us the responsibility we have when we design randomized studies, because bearing in mind the previously negative studies on treating basilar artery, so many centers did not want to randomize anymore because ethically they were saying, well, we know the success rate of mechanical thrombectomy, and we know that IV lysis has a recanalization rate of 4%, 95, 96% with mechanical thrombectomy. So people were very reluctant, and very often there was a huge crossover in patients who would originally be randomized to conservative, but then were treated, but the analysis were intention to treat analysis as well. And also there was no cutoff on severity. So you had patients enrolled with an NIHS of 1 who were in there. And again, we did not consider the complexity of the anatomy, because very often we have filling from the anterior circulation. We can have a primitive trigeminal artery, for example, as the extreme, where we think there's a blockage. So I think very big responsibility here, and very important, as you did, to look critically at the data that is available. Now, I would be interested in two things. And number one is, do you have any special imaging that you use for the posterior circulation to determine what is still rescuable? And let's start with that.
Yeah, in fact, in the majority of the cases, we are performing a CTA. And the CTA is very important for two reasons. One, of course, to know what is the target zone. And second, to plan the procedure, to make a mental rehearsal of the procedure in order to have a good success. So, and this is in fact shortening the time of the intervention itself, and it's very important to make, let's say, mental simulation of the intervention based on the imaging.
Perfect. And do you use MR if you have an unknown time window and you want to determine how much is there?
Yes, exactly. In case we have enough time with particular patient, we are using also MRI investigation and perfusion imaging.
Yeah, so I think this is really important in the setup, that you have a fast pathway for MR imaging in these patients to really determine what is the brainstem, how much is already there, what are we fighting for.
Exactly, especially in late comers, the MRI investigation is very important.
And can I ask also the team, what did you use for your anticoagulation, antiplatelet regime, especially the antiplatelet regime in the acute phase in the patient, because you're putting in a stent now?
Yeah. In fact, we are a little conservative regarding heparinization during the procedure. We are using 2,500 of heparin, and we are giving next day clopidogrel to these patients. Yeah.
And did you give anything in the acute phase, or was the patient on anything beforehand?
In case we don't like the flow, I'm using tirofiban, and we had, by the way, last week we had a very similar patient, and with tirofiban continuous infusion, the flow improved a lot.
Okay, what would you use with the rest of? Rest of the panel.
I just wanted to say, Ivo, that's a great talk, and thank you so much for sharing. Of course, you know, we'll be discussing how to start the stroke center in a good way. This is a hard start, because that's one of the ways, taking the patients that nobody wants to take. The important communication that needs to be made, somebody needs to call you. And I will be showing some less lucky patients that there was no call made to Ivo Petrov, you know, to save the patient. Now, you've touched really important point, both you and Professor Grunwald, you know, what to do with the guidelines. Do guidelines really require randomized trials?
Yes.
And there's also another element, there's a selection bias. A lot of people do not these days get entered into randomized trials. They're treated outside the trial once you know or you believe that the treatment works. So really the question is, would it be ethical now to do another trial in basilar stroke or, say, carotid-related stroke, just to provide the evidence that the guidelines can use, if the trial can go wrong for a variety of reasons? So I think those who are really writing guidelines need to take a wider view and understand that evidence-based medicine is not only just about the randomized trials. Sometimes you do not have an adequate randomized trial, and still you should guide people to perform intervention rather than, letting this patient that we showed die. That's fantastic, and like I said, we sometimes we would like to start with the easier patient. You have many of those hard starts, but that really establishes your role, and then it's the word of mouth that goes, the patients are getting saved. So congratulations.
Yeah, absolutely agree.
And a nicely cited example here is we don't have a randomized trial that parachutes work in a plane. So do we really need the randomized trial? And I think Piotr has raised a really important point here. We can gain a lot of data from registries.
In fact, it's possible to change the guideline based on large registry, large series, meta-analysis of this large series, individual series, and it will be not level 1, level A, but it will be an indication to continue treating this patient, because otherwise the prognosis is very poor.
Absolutely, absolutely. And I will already ask Michelle to come to the stage. There's one more question to you, but no, there's one more question.
No, I will answer about the double antiplatelet therapy, nothing's more.
Okay, yes, because that was really important about the antiplatelet therapy, and that was used. What do you use in the antiplatelet?
I switch between with prasugrel because we don't have a resistance, and I feel safety about the patient below the 17th. That I think that the complication it's with clopidogrel it's similar, and for this reason I switched to prasugrel.
Yes. And so especially in any intracranial stent, we would always try to give something more than just, for example, IV aspirin. We have recently been using cangrelor in addition.
For sure. In case of stenting, definitely we give double antiplatelet. For sure. Probably for one mount, it's enough, but in case of stenting, we give double antiplatelet in all patients.
But when do you give it, Ivo? Because the question is when. How soon after the intervention,
In fact, next day, overnight.
The second one, and you have aspirin on board during the case?
Yes. In the majority of the cases that are not with high hemorrhagic risk, even we are uploading the dose on the table after the procedure.
And I have to say, I like your a bit of heparin, Professor Grunwald was always telling us, stay away from heparin, We also had some
I know that many of you do zero heparin. I feel a little uncomfortable to do zero heparin.
Sometimes even not in the flash,
We stay to 2,500.
But regarding the heparin, it depends because most of the patients with the posterior fossa, they already received IV lysis, and this is the reason why
we will excuse Ivo, who's got a live case.
Yes, if it's already the patient already received the IV thrombolysis, I don't use heparin. But if it's directly in the angio suite, I use.
I think that this issue will never be resolved for one answer for all the patients. Unfortunately, those discussions were ongoing. I remember in the coronary field when people were thrombolized, and then a lot of people were saying, don't give heparin after thrombolysis. Then they got all combined, and like you said here, the picture is much more difficult because the risk of hemorrhagic transformation needs to be there.
Posterior fossa is a different space. In the conclusion, actually, we should decide patient by patient. So this is
I think this is important to do the individual decision because we do not know if the patient has had any clopidogrel beforehand the day, so it will be a decision. Main part is there's a big difference between extracranial and intracranial stenting. So with the carotid stenting, it is very well possible to use IV aspirin alone, for example, whereas intracranially, we do need something stronger. And it is really important after you place the stent to wait a moment to see that there's no thrombus formation, and rather than to, stent is placed out, and then you find that you've got stent occlusion. And be prepared that it could happen. And another thing is Cangalore, which is a beautiful drug because it works within a couple of minutes. But if the patient needed to go for decompressive surgery, especially in the posterior circulation where there's not a lot of space, the Cangalore can be stopped and the half-life time is only 5 minutes. So that is one big advantage rather to giving more aggressive antiplatelet therapy.
How many more years until it becomes generic?
Yeah, not exactly, yes.
Is it 5 years or 10 years now? Is it 5 years or 10 years now?
It's not that long. It's not that. I'm not sure. I'm not sure. But then the price will definitely go down. Perfect. Great discussion. Maria, thank you.
So thank you for the invitation. It's an honor for me to be here. Good morning to everyone. We will talk about the evolution in aspiration catheter. So we treated the first patient with Professor Grunwald and Professor Wright in Homburg, Saarland in 2006. And this is a patient that was a soldier. He had a fat embolus that was of fat, so there is no wonder that the thrombolysis didn't work. It was an M1 occlusion, and the catheter then looked like this. You can see they are a lot smaller and they have much separators. And the idea is to go through the thrombus several times with a separator under direct aspiration in order to prevent souring of the fragments. Aspiration has come a long way since then, from the basic tube focus. Until 2019, there is establishment of large catheter aspirations with focus on trackability. And now there are from many companies, and we are in the so-called smart design area, where we want to maximize the first pass effect. It's not only getting the size bigger, but also involving the engineering with the segmenting bore and bevel tips. For example, why we want to optimize first pass effect? Because it leads to better clinical outcomes for the patient, it shortens procedural times, it reduces device exchanges, and potentially leads to lower costs. The engineering improvements, the inner diameter of the catheter is larger, so they have a stronger suction column. There is pushability and flexibility. They have better distal tips with adramatic profile, and all these facilitate the improvement. They improve the end block extraction of the clot. And now we are able, with these catheters, to go through tortuous vessels that are potentially dangerous, like in this example. Why we invest in aspiration? The ASTER study has shown, and the COMPASS study also, that aspiration is not inferior compared to stent retrievers regarding the clinical outcome of the patients, the revascularization rates, and the first pass success. It has similar safety, but it reduces the time of the procedure. So there is a shift globally towards aspirations catheters as first time pass. The ideal vessel are straight vessels, proximal occlusions, and vessels with minor elongations. The technique, we know it's the ADAPT technique. So we have to bring to the proximal side of the thrombus aspiration catheter through a microcatheter and a macro wire, and then we can perform push and pull, manipulate the aspiration tip so that we can have a perfect attachment of the thrombus to the aspiration tip, and then under continuous aspiration, retrieve it slowly. How to aspirate? We have two ways. We can use a syringe or we can use a pump. There is also a great evolution regarding the pumps engineering from continuous aspiration to we have the cycle aspiration that is shown that it reduces the fragmentation of the clots. And now there are flow sensors where the pump stops to aspirate when it notices that the aspiration tip is not attached to the thrombus, so it reduces blood loss during the operation. And catheters are getting even larger. We have in the market super large bore aspirations catheters. There are catheters who have a larger inner diameter of 2.24 millimeter and an outer diameter of 2.6. So they can, in one pass, we can take away, especially in larger arteries like the terminal branch of the internal carotid artery or the basilar artery, we can remove the clot completely in a single pass. But they have some disadvantages. They are larger and therefore they are more rigid and they can cause dissection and vascular injury. There is a question if we should use them in M1 vessel occlusions because they can cause a complete occlusion of the vessel, and we know that the pressure on the clot is higher if we have some undergrade flow. If there is some blood between the aspiration catheter and the vessel, we have better, we can remove easier the clot from the vessels. So now we can measure the vessels and have an aspirator tailored to the vessel size. They are also getting smaller. We know that the escape distal and discal studies were not positive for mechanical thrombectomy, but we still have to deal with MIVOs and distal vessel occlusions, especially in patients that have severe deficit, if we have an occlusion of a dominant artery, in younger patients, patients that are not eligible for thrombolysis, and of course in secondary middle vessel occlusion that occur during our procedure. We have dedicated catheters that are low-profile devices, longer, have distal trackability. It's important to know the vessel size, the correct size, because it minimizes the risk of oversizing and collapse of the vessel. And before aspirating, we can make sure that the catheter is in contact with the clot, because we're dealing with distal narrow vessels that are prone to injury, and we have an increased risk of perforation dissection. The technique also in this distal vessel occlusion is similar. We still have to bring with the microcatheter and microwire our aspiration catheter low profile to the site of the thrombus. We can use a coaxial system. We can leave a bigger aspiration catheter in M1s by bifurcation in order to stabilize. We extract also with under continuous aspiration. And of course, we can combine all these aspirations catheters. We have many sizes. This is a case of a combination of super large bore aspiration catheter with a large bore. There is a primary occlusion of the carotid terminal part of the internal carotid artery, and ME1 occlusion. It's a case of Dr. Mamalis in Greece. And with the combination, he was able to achieve recanalization of both vessel sides. What are the limitations of aspiration? Distal vessel occlusion is always a limitation. Tortuous anatomy, elongation of the vessels, it's not always easy without using stent retriever and anchor techniques to bring the catheter to the right sides. And also occlusions in the bifurcations can be sometimes difficult to retrieve only with aspiration technique. And if it doesn't work, we know we can always combine them with stent retrievers. If we're dealing with distal vessel occlusions, it's nice to have a pre-selection of length-compatible devices before we start our treatment. In conclusion, a modern thrombectomy success is the combination of engineering, physiology, and strategy. Thank you.
Thank you for the presentation. Do you have any experience with cyclic aspiration? Not continuous, but cyclic.
I think all the pumps now, they have integrated cycling aspiration. They don't have this continuous, but it's integrated in this next generation pumps. They have the cycling aspiration. I don't do it manually. Yeah. When I use the syringe, I do it once and take it all away.
And do you see the difference maybe with the old ones and cyclic or continuous?
I have also very good experience, very nice experience with syringes, but I think it depends on the length of the thrombus and if it is hard or it is very soft. If it's hard, you will need the pump, you will need continuous aspiration, cycling, you will need to something else apart from the syringes. I primarily use the syringes, and then if it doesn't work, go to the pump.
Thank you very much, Mary. And I'm pleased to announce our next speaker. Thank you, Mary. And it is Dr. Phillippe Dodier who's going to speak about first robotic microsurgical experience in Austria. Thank you.
Thank you, dear chair, dear panelists and colleagues. First of all, thank you for the invitation, for coming back to this amazing and this professionally organized event. After talking last year about the history of bypass surgery, so I'm going to take you in the next few minutes away from endovascular treatment, despite being a dually trained neurosurgeon. I'm going to talk about the future, at least what is coming next in the pipeline. We received no personal financial fundings for this project I'm going to present to you. And there are already established indications. So for certain neurosurgical diseases, robotics are already here, and this for many, many years, especially biopsies, electrode implantations, and DBS. And for the general surgeons, pediatric, urologic, gynecology surgery, the Da Vinci robot has changed it all. And if you just think that the robot has been introduced more than 26 years ago on the market, it took quite some time to get to the stage it has now. But for microsurgery, and especially for the intracranial ones, it took some time. So we had the chance a few years ago, at the beginning of the pandemic, to be trained on the CorePath system that unfortunately did not make it to Vienna, had to be pulled out of the market because of the inability to work in a three-axle fashion, and so they are working on it to make it better. And we're going to hear, I think, in one of the next talks about robotic-assisted endovascular surgery and interventions. But right now we are in the pre-robotic age for bypass surgery and revascularization. So last year I presented to you the step-by-step measures of performing these, let's say, very rare but very important procedures also for revascularization and ischemic patients, especially mesory perfusion, under best medical treatment. And this is a very, let's say, very important and often cited paper and figure from Helsinki, being the, let's say, Mecca in Europe for open surgery for many, many years. And you see that just a few years ago, there was this crossover from open surgery to endovascular treatment. So even the reality has stroked there. And this crossover happened in Vienna 10 years before. But still, robotics are now arriving, and these are the two devices that are not yet certified, but are going to be in the very foreseeable future. The Musa 3 from the Netherlands, and the Simani from the company MMI in Italy, the one that we were able to work with for a short week. This first system, Musa, is very interesting because it lets you introduce your own instruments into the system. And it has a very, let's say, Da Vinci-like experience where you sit away from the patient at the workstation. This is going to be the Musa 3 that should be and receive the certification soon. We received, let's say, first insights from Professor Nosek from Langone from New York just last year at our conference. So they are very, very far ahead in their certification process. And this system here, the Simani, is let's say, a different concept. It has proprietary instruments like the forceps, the scissors, the needle holder already integrated. and your control usage is with joysticks being at the table or away from the table. It is especially already clinically established and certified for plastic surgery, so especially for supra microsurgery with sutures of 10 and 11.0 of thickness. And this is what it looks like, basically. That's you have a system that is working like a macroscope kind of system that is close to the surgical site, and your movements are being translated in up to 20 times slowlier and without tremor to this revascularization exercises. Already being published, especially for lymphovenous anastomosis extracranially, and the Vienna experience consisted in including all the microsurgical experts of our hospital. We're a rather large center, meaning that we had 30 participants spending each 1 hour of the system to see how fast they would be trained and introduced to this novel technique. We also invited biomedical engineers and included also our simulator that we presented here last year, the SIMI simulator, into the system. It was a setup. And here, basically, the stepwise approach, the progressive approach from pick and place to artificial vessels up to the SIMI simulator, that's helped us in less than 1 hour to get the understanding of the simulator, and especially of the SIMIS device. The simulator has been continuously improved. Last year, we presented the clipping application. Now we are preparing a manuscript for the endovascular approach, for the in-house printed patient-matched system, and now we're introducing also the bypass revascularization SIMIS model for this robotic training. This is what it looked like. We had this perfused and basically connected vessel system simulating craniotomy of 3 centimeters in diameter. It's what we do as well for the open surgical procedures without robots. And it was able in less than 3 hours to be trained in a way that you could perform this technique in a very, let's say, competent way. Again, it was a very, let's say, short time. Of course, in less than 3 hours, you cannot expect to have massive amount of data to support what we are presenting. But still, the questionnaire that was sent to all 30 participants demonstrated that both the training, the haptics, and let's say the reduced time that they spent on this model was sufficient to get an idea if this learning curve was enough to be in the future introduced in their subspecialties. The outlook is that this system has already been certified for extracranial anastomosis and revascularization. So for us, in neurosurgery, it's not there yet, but it should arrive in the next few months. What is still a matter of discussion is how to introduce our different types of visualizations, like the microscopes, the exoscopes, and even the combined devices, can work seamlessly with this device. Like here, one of the big names in neurosurgery, Professor Penetsky from Vienna and later on of Mainz, who spent even an entire book and part of his career to really optimize endoscopic techniques and the team-based approach. And this is, I think, where we are now with the robotics, how to implement it in the safest way for the patients. A very, let's say, controversial, but let's say the one that makes the most buzz internationally. It was just yesterday, I think, in the Forbes magazine. That's for eventually new and future indications that we haven't been thinking of previously. Like Alzheimer's is something that the robotic company is looking into, but I think that we are very, very far away from this point, that there is no established evidence yet on using bypass surgery to treat Alzheimer's as for now. But what we are using now and taking the time that we know that we are almost in the robotic age, but not there yet, is how to improve ourselves, how to improve even the specialists over time. So we developed as an accompanying device to our simulator also the tremor and dexterity measurement application for smartwatch that we are using on both hands, and are training residents, students, and even experts to improve the dexterity, the ambidexterity, to at least try to achieve what the robot will do in the future. All right, I think we have said it all. Thank you very much.
Can I jump in with one question? Thank you, Phillippe. Great presentation. So you mentioned briefly Corindus. I know Corindus is now being bought by other company, and it is removed from the market. Do you have any experience with Sentante?
No, not yet. But I'm very looking forward to the next.
Because
talk.
I think their approach with removing of joysticks and everything in robotic is actually better.
Absolutely.
Yes, it's really impressive. If I understood it correctly, it's much slower than the operator.
Well, the device lets you type in the division number of how you want your movements and your tremor to be split. So it's, I think, 4, 8, 12, and 20 times. So depending on the level of magnification of your microscope, when you're placing the suture inside the vessel wall, where you want to see in those millimetric or even submillimetric vessels, then you will want to have the machine, the robots, to really translate your movements up to the slowest and least amount of tremor to the patient. So you can decide yourself.
You can decide yourself. So if you have, I'm sorry, if you have to move quickly for complication, you have to let the robot and go yourself in.
This is always a part of the certification process, is what happens if something goes wrong. It has to be manipulated in a way that it can be taken off of the patient, of the OR table, so fast and safe that you can take over surgically. So this is why at least the cases that we've seen until now are being performed in a surgical gown, sterile, very close to the patient, so that if something happens, that you can take over and do it manually.
Again, thank you for the wonderful presentation. I have a similar question. Do you have some delay between your movement and the movement of the robotic arm?
Well, it's basically the same when you perform the anastomosis, the suture itself. When you're performing the knot, you're zooming out and you're doing it much faster than when you're placing very diligently the suture in the needle. And this is the same approach with the robots that basically lets you decide how fast and how slow you want it to do and how safe.
Thank you.
Perfect. Thank you very much.
That's been an exciting journey in the future. Can I just ask, because one thing is feasibility, the other thing is indication and benefit.
The most important.
You touched on some points. I understand the increased precision of anastomosis, yes, would be the increased precision of the anastomosis would be the one benefit. What are other benefits?
Well, in the end, the indications for bypass surgery have, unfortunately for us, gone down massively in the last 20 years. So, of course, the number
less and less people who can do it well. You know, I don't know anyone in Poland.
This is basically the main marketing argument for the companies, for the robotic companies, of course, in the future, because the Da Vinci is already measuring everything you do. It is documenting everything you do. And in the future, I think that these companies, that the new ones are going in the market, will do the same. It's becoming more and more automatic. And then there will still be the necessity and the requirement for the surgeons to be in control and in charge to basically double-check what the robot is going to do in the future.
But it means that the native surgical skills will go down.
This is why we need centers like Dundee, need centers like Rome, and centers like Vienna, where you train people, and where basically the training process becomes an intuitive part of residency and of training the future. We're now training even our experts to become more and more dexterous with their non-dominant left hand, to exactly address these issues in the future.
So the main advantages would be?
The main advantages are going to be that the training levels are going to be more structurized, that the few residents who still want to go into this revascularization pathway are going to be trained in both manual and robotic assisted surgery, and that they're going to be trained not like us. Most of us have been trained on patients for many, many years and decades. It was okay, but now it's becoming not okay anymore. Now we're training on models that are going to be lifelike, or life, absolutely realistic, and therefore this is the way that we should go.
Thanks so much.
One more benefit is to remove us from the X-ray to the other room, and then we can do it.
Absolutely, for endovascular, of course. For surgeons, neurosurgeons, X-ray is not that much of an issue.
Thank you very much. I very much believe this is the future, endovascular or robotic-guided or assisted interventions. Thank you very much. And we do actually have Sentante and Thomas here who's going to give a talk after the break. But so that we get to our coffee break, I would like to announce our next speaker, Piotr Musialek, who's going to, last speaker before the coffee break, and you're going to speak about tandem lesions, micromesh stents, and embolic protection choices when MoMA isn't available.
Thank you so much. I didn't know how to really tackle the problem because, MoMA is irreplaceable, as I think you will understand from the talk. Tandem stroke. Tandem stroke, a problem? Not a problem, Dr. Politi? You see them? Okay. So tandem strokes, we heard this more in some regions in the world. In Scotland, there seems to be more than 20 or 30%, but these are about 20 to 30% ischemic strokes are associated with carotid atherosclerosis. Part of those strokes are tandem lesions. Tandem lesions are bad, mostly, because now you imagine that you have to deal with this mud, not only at the carotid level, but also some of this mud would be in the brain. And form a tandem lesion. So they're bad to have, they're associated with bad prognosis for the patient, and they are bad to treat because there are challenges with treating of those lesions. The outcomes in carotid-related stroke are bad. This is a bad disease when you look at the natural history. This is an example real-life example from one of patients. In my hospital, I have to say, a few years ago, this is a 52-year-old teacher who comes and occludes right internal carotid artery. This results in a TIA. This is not reported, not treated. Good brain, aspects 10. Day 3, she develops in hospital stroke with large analytic stroke scale, still good brain. She receives CT and urgent neuro consultation. She's referred to Comprehensive Stroke Center for reasons unknown to us. She gets rejected, so we observe natural history. This is ICA acute occlusion. The local team is not activated that would be capable of addressing this issue. You see the natural history, large ischemic stroke. Fortunately for her, she inherniates and dies on day 6. So this is one of the scenarios in natural history and why we treat those tandem strokes. Distal embolism is a problem, 20 to 30% cases, unless you use special techniques to reduce its likelihood. Another problem is stent thrombosis that is associated, apart from the problems with double antiplatelet therapy, the challenges of DAPT in the setting of acute stroke, but also sometimes with leaving undersized or using undersized stents. So for tandem lesions, you need to protect the brain against further injury, embolism, and you need to minimize embolization during all procedural steps. That's important for carotid artery stenting as it is for emergency carotid artery stenting. This is the paper from Professor Grunwald and the team some years ago that really provided level 1 evidence that proximal protection, flow reversal, in this case with GORE, flow reversal system, reduces the embolism to the brain. This was in elective CAS. There were other papers following. You look at DWI evidence, or you look at microembolic signals. There's strong evidence that proximal protection works. This is the clinical data from the GORE flow reversal study some years ago that we participated in. Here I put the data from different studies. You can see the different procedural steps: lesion wiring, predilation, stent positioning, deployment, stent post-dilation, unprotected, filter protected versus MoMA protected. How we can really knock down the embolism. This is an example of the patient treated with proximal protection. You can see recent stroke, thrombotic lesion. You can see here the balloon. This is the balloon of the MoMA system, the different stages under flow reversal, micronet covered stent, fully optimized, under proximal protection. You can see 0 residual stenosis, full endovascular reconstruction of the vessel, and 0 new cerebral lesions. So proximal protection is really important. It also works in carotid-related stroke. This is the data from Safeguard Stroke Study. Balloon catheter use, it was mostly double balloon catheter systems increased the likelihood of good clinical outcome. Now, MoMA is not available. There would be future MoMAs coming, I'm sure, to the market. There's some enthusiasm about the use of a mono balloon catheter that works with large bore system, such as TCAR system, when you can reverse the flow from both the external and internal carotid artery. But here the advantage is the diameter or the radius of the system. The flow is proportional to the radius to the power 4, so even a small change in the diameter of the system results in a large difference in flow. So with those large bore systems, you may forget about the need to exclude the external carotid artery, but this is not the case with single balloon system. This is the MoMA. As you can see here, the flow reversal under MoMA. Some people say, well, it's not possible to perform transfemoral carotid stenting with flow reversal. So I'm showing, yes, it is possible. This is something we've been doing for years. The procedure, the brain is fully protected starting from the moment of wiring the lesion, continuous retrograde flow with the MoMA flow reversal system. This is the monoballoon catheter. One of the few cases that it works. You can see uncontrasted blood coming from the brain in the internal carotid artery to the common carotid artery. So in this case, the procedure can be protected with monoballoon catheter, but what usually happens is the flow from the external to the internal carotid artery. So someone sticks a monoballoon catheter in the common carotid, they think they protect the brain, but in fact the brain is not protected. There is some low-grade reverse flow, but a lot of blood, as you see, is coming from the external to the internal, so we have 0. This is a fully unprotected procedure. That's another example of a fully unprotected procedure. You can see the flow again from the external to the internal. So somebody thinks they protect the brain, they stick a monoballoon catheter in the common carotid, yet this flow from the external to internal totally precludes any kind of cerebral protection. So we've recently wrote this commentary with Professor Grunwald about the illusion of occlusion or illusion of protection. All depends where the balloon guide is placed. If this is scenario A, which is typical scenario in interventional neuroradiology, so for non-tandem lesions in the internal carotid artery, you protect the brain. But then if you move this monoballoon catheter to the common carotid artery with a flow from external to internal, there's no brain protection. You really need to add another balloon to exclude the external carotid artery unless you perform high flow reversal, so dynamic flow reversal, like with TCAR, transcarotid access, then you are likely to have protection by reversing the flow both from the ECA and ICA. This is an example of TCAR, but this requires surgery. I don't know what your views are in the future about possibility of going transcutaneous, percutaneous. The environment here is not very friendly. Sometimes the artery is very deep, and there's a risk of carotid blowout phenomenon. I don't know, have you gone direct, Dr. Politi, Iris, in any cases? No, okay. So this requires the help from the surgical colleague, and you can reverse the flow. This is an example of a thrombus-containing lesion here treated under flow reversal safely again with a micronet-covered stent exclusion. This we discussed during the previous talk, how you can get trained in tandem stroke management using the cadaveric stroke model. Now we believe it's also important to fully exclude the plaque, because if you remember my first image, now if you stick a stent into this mud, what happens is that you will have after you place stent, continued passage of the mud to the lumen of the artery and then to the brain. There's now level 1 evidence against the CREST study stent, so an open cell stent. These are some images from optical coherence tomography, intravascular imaging, that the use of the micron covered stent really knocks down the magnitude of ischemic lesions to the brain. The curves on the left, this is logarithmic scale, so if you look at per lesion or per load to the hemisphere, in this randomized study with external core lab, there's a huge reduction in the embolic load to the brain, translating into clinical benefit. There's also now an FDA IDE trial, so that included also those very complex patients, so no cherry picking for trying to get a good result of the study. You see also proximal protected cases. You can see cases with flow reversal here. Again, for full protection of the brain. Note smart fit of the device, good alignment with the anatomy, with the curves. The stent is very largely open cell stent when it comes to the frame. Outside the nitinol frame, there's micronet that prevents the passage of the plaque material into the lumen. The best clinical outcomes in an FDA study so far ever performed. Is another study that I'm showing paradigm data only for the sake of the fact that if you optimize the stent, if you do coronary-like optimization, you can end up with instant restenosis rate of less than 0.5%. So we believe this is changing the paradigm. Those carotid lesions are treated. This is the predilation. You see the balloon sizes. This was a sample of the first 500 patients, 533 procedures, effective post-dilation optimization of the stent. Transcarotid has been mentioned. Of course, you can combine the two techniques with very good clinical outcomes. The long-term data are coming. This is 5-year data in the initial study, so no stent-related issues. Now we've added the third arm to the randomized study by testing the effect of proximal protection and the micronet covered stent. This is the third, the line most in the bottom, those points. Note that there's 100 patients there. The two other arms have 50 patients. So if you look at even and odd patients, so 50 patients in each arm, this is what you really see. Further reduction of cerebral embolism by combining the intraprocedural proximal protection with also post-procedural protection against embolism with micronet covered stent, and consistent outcomes you see in the 3 studies that are superior to the outcomes in carotid, prior carotid trials, really establishing the new benchmark for carotid interventions. So carotid plaque permanent insulation is the first-line therapy, we believe, for all carotid artery stenting, including emergency carotid stenting and for TCAR. Advances in carotid interventions, including emergency CAS, improved cerebral protection, anti-embolic stents, translate into significant improvement of outcomes. We are really changing with treating those tandem strokes that, some people, I don't understand it, say that separate evidence would be required, a separate study. We discussed this in the morning, would it be ethical to include patients in this study? This is our registry, really showing that you change the fate of the patients. This is some other cases with proximal protection. But it's important to know, again, we discussed the training all this morning. You need to know how to exert, to use the proximal protection. You know how to reverse rather than just arrest the flow. And the best thing you can do is to pair it with an anti-embolic stent for also post-procedural cerebral protection. Thank you so much for your attention.
Any questions? Piotr, what is your message to companies, one word, regarding proximal protection?
Well, the double balloon system is definitely needed. What the company said, I spoke to the president of Medtronic twice in November. The company, what they're really interested in is the profit they make and the number of devices they sell. One issue with proximal protection is that because it's counterintuitive, some people don't know how to use it. They would stick a filter through a thrombotic lesion still. So training is really important. In our study, we've been doing 50% of cases with proximal protection. So the message to the companies is, of course, give us the devices, but for a company to give us the devices, they need to establish the size of the market. So our part is to increase training in proximal protection. Now it's also on a simulator.
Thank you very much. And with that, we conclude this part. Let's go for coffee. And if you could all be back in 15 minutes at 12:15, where we will have an exciting presentation from Thomas about robotic interventions and the first transatlantic thrombectomy. Piotr, thank you very much for this presentation.
And please come back from Thomas. It's going to be much more interesting.